Class begins now. Hi, I'm Dr. Schemmel. I'm a board certified emergency medicine physician. I stopped doing clinical practice in the area about 2 years ago, so I just teach slash torment. And I teach at Touro Medical College, and I teach here, and do some other stuff. I've worked all over the country and masters. And so today's endocrine, hormones. And basically, it's little itty bitty particles that have a huge influence on your body. If you think of how much hormone weighs, it's like you're looking at nano amounts, but it really makes a huge difference for people. So my goal for you folks is to basically to think about people who have conditions that are endocrine conditions, and just say, maybe I'll see them on their break. Maybe they'll be presenting to me. My favorite is when I was in med school, one of my housemates ended up having a thyroid storm. And she was a little bit wacky beforehand. She was a little bit thin, a little bit high strung. And when she ended up having a thyroid storm, it made perfect sense. But you never, she didn't have a psychological problem. It was more of a thyroid problem. So you have to think about, it's not just, they're depressed, they're anxious. It can be, but it can be from hormones, endocrine, exocrine problems, okay? So in the ER, we don't dismiss people, they come with anxiety, therefore we're not gonna check them out for a whole range of stuff. You need to be thorough with your workup, and they can mask as other problems. And when we go through the different cases, you can see how they mask. Let's just get some basic terminology done. If I am talking too quiet, too loud, too fast, too slow, please let me know. Or if I'm talking in gibberish, also let me know as well. There's no question too ridiculous to ask. You're here to learn, and I'm just trying to help you, okay? So, endocrine. So endocrine glands, basically, we'll make this go.
Hit the enter key on the keyboard if you'd like.
Okay. There's basically endocrine, which basically secretes into chemicals into the blood, or exocrine, which goes into the nearby tissues via a duct. Okay? You don't really need to know this difference. It's interesting. It's a fun fact. People can be tormented about it on exams, but it's not really that big of a deal. But the endocrine system affects the whole body, and it involves the release of hormones. It has to do with temperature control, metabolism, sexual development, coordination responses for environment and stress. It's everything. It's the master control, the computer that runs your body, and there's all different hormones, exocrine and endocrine, from a whole range of systems. Okay, so we're just going to go through some. Okay, so basically, messengers. So they're just basically messengers that can come from the hypothalamus, parathyroid, adrenals, gonads. Even your fat will make hormones. Isn't that exciting? Fat. So you can get estrogen and testosterone from adipose tissue. So, okay. So let's just go on the odyssey of. So we'll start at the head and work our way down. Does anyone know where the hypothalamus lives? In your head ball. Very good. It lives in your head ball. So it's deeper than the cerebrum, which is the back part, and that's coming towards the front area. Here. The pituitary is, if these are your you have eyeballs, right? And your pituitary lives, and you have the optic chiasm, which comes from your eyeballs back to your brain, like this. Okay? The pituitary sits right underneath there. Does that make sense? Right? To draw a bad picture. And so what happens if someone has a problem in their pituitary, guess what happens? You can present as an eyeball problem, blurry vision, headaches. Okay? So location matters. That matters that the hypothalamus is in your head and not in your stomach, not in your intestines. And basically, the hypothalamus, there's two ways that it can give information to your body. One, it can go through a duct where it sends the hormones down into the anterior pituitary, or it can go into the bloodstream. Fascinating, right? Oh, that's just really interesting, except there's two different types. There's an anterior part of the pituitary, and there's a posterior part of the pituitary. So if you have a problem with the circulation, it's going to affect the posterior part of the pituitary for someone. But usually if someone's having a pituitary problem, they, again, will present with visual stuff because the location of the pituitary gland will affect the optic chiasm. And so the hypothalamus produces hormones, and the main one is to have a hormone released, you have to have a releasing hormone, you have to slow it down, you have to have an inhibiting hormone. This is all very interesting in terms of managing and controlling how the hormones work. But the basic thing is, there's a growth hormone, helps you grow. There's a thyroid stimulating hormone. There's one that affects the adrenals. There's one that affects the sexual hormones, estrogen, progesterone, and testosterone, okay? And there's one that affects the thyroid. So those hormones that affect all the glands in your body, okay? And so these are the lists of them. The main thing is that to know that there's the anterior and the posterior. The posterior has two hormones. Posterior responds to the nerve. Anterior has the duct. So anterior has, just think anterior has everything, and I'm just going to remember the two things that are in the posterior. Does anyone know what the two things are in the posterior? ADH. What does ADH respond to? Why is that important? Blood pressure, right. Volume. Your body has volume, and if you have decreased volume, you want to have an increased volume, so you're going to increase the antidiuretic hormone, i.e. the anti-piss hormone. Okay? It's easy to remember it that way. I drink alcohol. Alcohol poisons my antidiuretic hormone. What does that translate to? When you drink alcohol, what happens to you? You pee like crazy. The reason you pee like crazy is because the antidiuretic hormone has been poisoned by alcohol. Okay? Easy way to remember it. I just poisoned part of my hormone system. The other one that it works on is oxytocin. You know what oxytocin does?
Stimulates human contractions.
Yeah, stimulates human contractions. Makes breast milk come down, and when women are in labor, you want oxytocin to happen because it will help people have labor. Also, what does it do for guys? Think oxytocin has any function for males?
Increase mood, right?
Mood?
Yeah.
Sure, it helps you. It's involved in ejaculation. It's involved in testosterone production as well. Okay? So the two to remember what goes on in the posterior, which is basically ADH, vasopressin, response to volume, and oxytocin. All the other ones I just said, the ACTH, the growth hormone, the TSH, the LH, the FSH, are in the anterior, okay? So memorize the two, okay? Know their function, and then you know the rest. It's an easier way of doing it versus trying to sort everything out. There's only two. Questions so far? So when someone drinks alcohol, you can just amaze them with your intelligence and say, oh, God, poison. Anti-piss hormone, anti-diuretic hormone. Okay, so the anti-diuretic hormone vasopressin works on your kidneys and helps you reabsorb water because it's very volume sensitive. Okay. Here's all the anterior stuff. So it's pretty easy to guess if your ACTH that affects the adrenal cortexes doesn't work, what's going to happen? The cortisol hormone, the aldosterone is not going to be released. Okay. Let's go into some. So, my housemate had a thyroid storm, okay? That has to do with the thyroid hyperthyroid. What does your thyroid do, basically? If you can have too much of it, you can be hyper. Your thyroid basically is the thermoregulation, is the metabolism regulation for your body, okay? So she had a storm where she was crazy. Her heart, what happens when someone's thyroid gland produces, or you have too much thyroid stimulating hormone in the body, too much thyroid, what happens to your heart? Tachycardia, right? It says go, go, go. It turns out. So she had SVT. She had high blood pressure. She was crazy. I mean, she could, well, think about it. You have so much stimulation, you can't sleep. What happens when you can't sleep? You don't do so she ended up having a thyroid storm. When you have a thyroid storm, you think of everything being turned up. So your blood pressure is high, your heart rate's high. What happens to your temperature? High. Yeah. It's really so if you had someone who's having heart palpitations, kind of a little bit paranoid, not sleeping, how would you try to stabilize them when you went to see them? What would you do? Is that rain?
Yeah. Yep.
2 hours of sunshine today. Okay, what would you do? What's the first thing? A, for air, right? Are they have an airway problem? Or they might feel like they can't breathe because the heart's pounding. You want to assess what their heart rate is. Fast? Is it SVT? Is it atrial fib? What do you think their body habitus is going to be like? It's going on for a while. Too much thyroid. Taking like you're on thyroid medicine, they're taking too much versus too high. Or they have Graves', it's an autoimmune problem. So they're going to be scrawny, hypermobile. They're going to be constantly moving. Does that make sense? Yes, no? Okay. Tell me about it.
He had hypothyroidism, he knew that.
Who's hypo?
He was hypo.
Okay.
But he was saying that, like, he just didn't feel himself. It presented like anxiety. He just didn't feel himself, his pressure was high, and his heart rate was high, but it sounds like
So it's hyper, not hypo.
and he kept saying hypo.
Or it's almost hypo. Oh, think about this. Because with the actresses, so the heart rate is slow. They're like earthquakes. They move slow. The reflexes are slow. They are, they are, I've mixed it with the their skin is thickened, because they have an extra protein that gets deposited, but they're just slow moving. They are cold. It can be hypothermia. The heart rate can be pretty darn slow. When you look at their eyebrows, they have thinning out the eyebrows, they can go all the way up to hip, they have eyebrow hair loss. So, those are the basics. You can have too much or too little. Too much, a hyper, too little, very slow. Think of a turtle slowly moving and going to torpor state. I mean, which is really slow. So, if someone's cold, or they septic, are they hypothyroid? So, the thyroid gland makes T3 and T4 and calcitonin. Calcitonin, as we mentioned right now, it has to do with calcium tablets. Where you have the balance of calcium has to do with parathyroid. Calcitonin will be able to receptor. So, T3, T4. Questions so far? So, if you want to like, Rory's how would you treat a thyroid storm? You want to put them on the monitor, see what their heart rate's like, right? Pretty fast. In the hospital, what we do is we treat them with corticosteroids. Yeah, corticosteroids like dexamethasone or hydrocortisone, because that basically stops the conversion of T4 to T3. It stops it. You guys won't do it in the field, but that's what we use. We just, not going to have any more T3, We're just gonna stop that right now. We're gonna also deal with their, heart rate. If it's too fast, guess how we're gonna slow it down? Beta blockers. Calcium channel blocker. Okay. If they're an SVT, guess what we're doing? Adenosine. So you'll be treating them the same, but you'll be looking at, they have other things that are going on. Why are we concerned about somebody switching gears? Now we're going to talk about the parathyroid, the calcium. Okay, calcium balance. Why do we care about calcium balance? Well, osteoporosis, but someone's not going to come to you, hi, I have osteoporosis. They might fall down and break something. But what would you see? What presentation will make someone have a high calcium? And what would you see? They'll have bone pain. They can be, sometimes people have high calcium if they have tumors. They can have high calcium that can affect their EKGs. A whole range of things. So our calcium is regulated in our body really tightly by two hormones, which is basically the parathyroid hormone and the thyroid. Okay. And the thyroid makes the calcitonin. So you have calcitonin, which will drop it. The parathyroid will increase it via PTH. Okay. And that's the balance. That's kept really tight. If you don't have enough calcium, your muscles don't work. If your muscles don't work, guess what happens to your heart? It don't work either. The blood vessels, they don't contract. They relax. Okay, so if someone has a problem with the calcium, you're going to find out. Okay. Questions? The thymus gland, the most important gland we have in our body. I mean, joking. It produces white blood cells, T cells. It's involved in our immunology. You don't really see too much that you come and say, I have a thymus gland problem. You might say that a lot of times people have a thyroid, someone will take out their thyroid, right? And the parathyroid lives right next to them. So a lot of times the parathyroid gets affected. So then they have a problem with the calcium balance. So if people's calcium balance is affected, guess what they can present with? I can't move my hands. Right? They're in tetany, or they touch and they just start going like this. It's a calcium channel. Now this is something that you guys know a lot about. Pancreas, right? So when I think of the pancreas and insulin and all that, I basically think of what makes our body work. What do we need? What does every cell in our body need? Glucose. Okay. So if we don't have glucose, our mitochondria don't work. If we don't have glucose, our heart doesn't work, our brain doesn't work, all those things. So where do we get our glucose from? Okay? So basically, we're energy hybrids. In that you eat carbs, right? You get polysaccharides, you get your glucose and fructose. Make sense? We eat protein, polypeptides, we get our amino acids, so we get our muscles. We eat fat, that goes into triglycerides, we can get fatty acids and ketones, right? But our body really likes to eat and to have glucose, right? So what makes, we have glucose in our bloodstream, what makes the glucose go into the cells so our cell can use it? Insulin. Yeah, insulin. So if you don't have insulin, then it's hard for our body, this mechanism doesn't work. Insulin doesn't go in the body, so what happens to the glucose? Stays in the blood and it gets higher and higher and higher and higher. So if it gets higher, we're going to say, well, what's our next sacrificial energy that we can get? Since we can't get the glucose into our body, we can get fat and into fatty acids and ketones. We can use that. Do you want to break down your muscles that you spent so much time in the gym getting big and buffy for? No. That's the last thing you want to break down. So if you have insulin, you can get the glucose into your body. If you don't have insulin, then your glucose level goes up higher and you will start to break down fats first. Okay? Fats, good. Triglycerides, fatty acids, and ketones. So does that make sense a little bit? Which is knowing the difference between type 1 diabetes type 2 diabetes. Okay? Type 1 is where there's no insulin. They have no insulin, they have to get exogenous insulin. So where does insulin get made? We have 3 lovely cells in the pancreas that we study, right? There is the 4. There's 4, but the 3 that we really study and pay attention to is alpha, which is, I'm going to give you, there's going to be a good table, which gives you the glucagon. Beta, which gives you the insulin. And it's important to know which type that you have. So beta gives you insulin, BI, insulin, alpha, glucagon, and delta gives you somatostatin. So our goal with the pancreas is to control our sugar level. Okay? Some of you are drinking coffee that has sugar in it, right? Chance, Dunkin' Donuts, wherever you go. How much sugar is in a can of soda? Enough?
Give me 1 second.
Give me one. Okay.
69 grams.
69 grams.
And added sugars is a total of 138% of your daily value.
Okay. Excellent. So, we have our body that the alpha is the glucagon, the beta is the insulin, and they want to regulate, okay? So my sugar, let's say, is 100. How much glucose do you think lives in my body at that time before I take that delicious Pepsi?
Yep.
Oh, cool, Pepsi. So I have about 40 grams of sugar running around in my body, 40 grams. And my insulin is saying, get into the cells so we can use it, okay? And it's going to decrease the glucose in my blood. And then I go and drink my Pepsi, which basically doubles my load of glucose in the body. Okay? If I don't have the glycogen, right? If I don't have the glycogen to push it into my fat cells, to put it into my liver cells, what do you think is going to happen? My sugar's going to go sky high. I just doubled my sugar level. So it's amazing to me that we don't have more people walking around with sugars of 200 after they have a Pepsi or they have a soda, because effectively you're doubling someone's sugar level. Does that make sense? So again, insulin is going to decrease the glucose in the blood. It's going to put it into the cells. Okay? Does that make sense? You got that? And glycogen is going to increase it in the body because you're going to need to use it. Okay? And then we have the fine tuning. Like, you know, these are big controls, and the fine tuning is a somatostatin, which comes from the delta. Okay? So, this is a picture that you have in brain. The rest of your life, I'm joking. Here's it in words. So glycogen is going to make you have glucose, and it's going to increase the glucose level. Insulin is going to decrease the glucose level. Somatostatin is going to fine tuning. Okay? This is really, really, really important to know. Because when someone is a diabetic, right, and they type 1 diabetic, but they don't make insulin, what happens to their sugar? Goes high, right? So how do people manage before there was insulin? How does your body try, when you have someone who's becoming a diabetic, okay, their sugar's higher, how does your body try to manage that?
Pee.
Pee. Yeah. Well, you pee all the time. What's so special about their pee?
They pee all the time.
They pee all the time. Because basically what they're doing is the glucose handling and the glomerulus is letting big particles of glucose go through. So if you have these big particles of glucose go through, guess what has to go through so it doesn't get crunchy and stone-like? Water. So you're having people pee out sugar water, basically. And what happens to folks if they don't drink enough? They get dehydrated. What happens to the electrolytes? They go down. Sodium goes down, potassium go down. So people will usually present saying, I've been drinking a lot, I've been peeing a lot, but I'm just keeping up, you know what I mean? I like my Pepsi, I like my Fanta, whatever it is, and they don't have an idea of what's going on because it's gradual process. But they will present with peeing, drinking. They will present with dehydration, hypotension, tachycardia. Does that make sense? And it's a very, and you'll see type 1 diabetics present. I guarantee you'll be probably the first person to see them and say, oh, I know what's going on. Because when you don't have insulin, what happens? How do you get stuff to your body to work? You break down the fat. So long ago, people who were diabetics type 1 who didn't have insulin, they were very, 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 very thin because they couldn't use their sugar. They were peeing out their fluid all the time. They were digesting the fat to make fatty acids and ketones, okay? Ketones, are they an acid or a base? Or I don't know. Ketone, they're an acid, right? So how does your body deal with an acid? I can blow off an acid. So you'll see them start to breathe more fast, more deep, because they're trying to compensate. The urine, they're trying to get rid of the sugars. Also, in the kidney, you can try to compensate with the acid by using the bicarb that's there. So the whole metabolic thing is going on. What does ketone smell like? Pardon? Acetone, which is what? Nail polish remover. Some people say, okay, it smells exactly like nail polish remover. Some people say it smells like grape juice. I don't understand why grape juice. One person I know swears that smells like grape juice. You walk into the room and you're going, you can smell it on their breath. It's that obvious when they walk, when they come into the breathe. So that's one of the first things that you'll see. So let me. So, I'm just going to go through diabetes. So if you have going through what normal insulin metabolism is, fat, because our goal is to have enough reserve so we can, when we're not eating, we don't starve. Insulin produced by the beta cells. Now, if you have insulin, it's going to drive down the glucose. I know I'm repeating it over and over and over because this is the most important consequence to get. So if someone just took a medicine that decreases their insulin, if someone takes a insulin and drives down their glucose level, what are you going to see? What are they going to look like? What are you going to see? Diaphragmatic, yeah. How's fermentation done? Your brain needs sugar, right? Altered. What's altered? I mean, I've seen people altered who are screaming, yelling, angry. I see people who are paranoid. I see people who don't make sense. How do you figure out if that's normal for you?
Ask around.
Ask around. Is this normal? Or usually people don't make, because someone not making sense and diaphoretic, could they be septic? Yeah. There can be a whole range of things. So we're trying to maintain our glucose level between 60 and 120. Someone can have a glucose of 60 and have normal mentation. Someone can have a glucose of 60 and be altered. So there's too much and too little. So type 1 is what I've been talking about, where they basically don't make insulin. And so they can get the diabetic ketoacidosis. What pH do we live at? 7.3, 7.4. So people can get acidotic down to 6.9, 6.8 I've seen. And they are trying to compensate. What do they look like when someone's trying to compensate? Doing tripoding and breathing really fast. I guarantee you will see people who will come in and their family members or them saying, I'm having an asthma attack. I can't breathe. I have allergies. I have pneumonia. Look how fast that person's breathing. And you walk and you go down that line of, wow, lungs are clear, the pulse ox is 100, and they can't breathe, but they're breathing really fast. You're seeing nasal flare, you're seeing accessory muscle use, right? And it's like, I smell something unusual. You're in DKA. Okay? So don't, just because someone's breathing fast doesn't mean it's a solely respiratory problem. With DKA, it's compensation. Okay? Makes sense? Yes, so. And they can get really, really sick because their body doesn't work too well in an acid environment. Our enzymes don't work. Our heart doesn't work. Our brains don't work. And so if someone's in an acid environment for a while because they can't compensate, they will die. What happens to your potassium in an acid environment? Does it go in the cell or out of the cell? Out of the cell. So we can have ketone forms, which is the acid, upsets the pH. How long does it take for someone to go into DKA? Are we talking weeks, minutes, days? When it first starts, when they hit the started making ketones.
Couple days.
A day or two. It's not immediate. It's like when someone drops their blood sugar, how long does it take for them to see a problem? Our blood sugar's down to 60, 50, 40. One percent is showing a problem. After a day. It's kind of immediate, right? It happens pretty darn fast. So, let's know about ketone inflammation. So it all has to do with we can't use the sugar, so we're using fat oil. We're hybrid energy users. It gets acidosis. So we try to compensate with respiration. That's why people present like asthma, they present like they have cold, they present like they have pneumonia, and they're dry, they look septic, they look really sick. They have this unusual odor about them. It's not because they haven't showered. And you're going to get good pulse oxes, fast respiratory rate. So these are the signs and symptoms what you're going to see. Tachycardia, hypotension. They're going to have a history of you peeing a lot, drinking a lot, weight loss, weakness, dehydration. And it's a slow onset, 12, 24 hours. Has anyone ever seen this at all? Is that similar to what I'm saying? What did you say?
Yeah, she was diaphragmatic. She was super. She had the fruity breath. She was doing the personal respirations, and she was really altered, like super altered.
Because you don't have glucose for your brain. A lot of times you don't have. You are the acid is what's really going to do it to someone. To make you act.
Actually, the second time I saw it too, was a lot human for difficulty.
Yeah. And it's usually someone who's a teenager.
This guy was like in his 30s or 40s, a truck driver. It was at the throughway.
It used to be that you could, if you were a truck driver about 5 years ago, you couldn't have diabetes. If you were a truck driver and had to use insulin as a disqualifier, you couldn't drive a truck. Since we need to have new truck drivers, because they changed the rules, and it's really hard for a truck driver to have good insulin, good sugar controls. Because what do they do all day? They sit. So it's one of the hardest jobs to be healthy at. Because they sit, they eat at truck stops, and it's just really difficult. They get in. So the thing that's really important is, as someone doses change the insulin, how they had a recent infection. What can happen when someone has an infection? Your sugar. What do you think the bacteria eat? Sugar. So your sugar can plummet, go down. Sometimes you can have a stressor, and your sugar can, because of the stress hormones, your sugar can go up. But when someone has an infection, their blood sugar will be out of control, one way or the other. So you have to ask. If you have a diabetic who has pneumonia or has a fever, it's going to change them. Why does psychological stress, we all have stress, why does psychological stress play a role in diabetes? What happens when you have stress? Cortisol, exactly. Cortisol levels, sleeping patterns, eating patterns. everything gets gone. So we have the diabetic ketoacidosis, airway, breathing, circulation, all these things that we say. Blood glucose level. So with what Annie had, how much sugar is in 25 grams of 50% dextrose? How much sugar is that? 12.5 grams. So you give someone 12.5 grams of dextrose, and their sugars can go up 60 to 120 milligrams per deciliter. You're taking in quadruple that amount with your Pepsi. What do you think's going to happen? It's going to go sky high, particularly if you're a diabetic. That's why diabetics can't have that. Those drinks. Well, they can't. The bottles do open people who drink it, but they shouldn't have it. But it's amazing to me that we don't have more people having poly or polydipsia because of the sugar that we take. So by giving them saline, why does saline work so well for DKA?
It makes Kool-Aid.
It makes Kool-Aid. There we go. It makes people pee sugar. Also will correct their low in volume. Because they've been peeing, so it'll correct the volume. Does that make sense? That's why you do it. And you want to get the transported as fast as possible because the potassium can drop. The potassium can look high because the volume contracted and you have acidosis going on, and actually the potassium is very low. So type 2 diabetes, okay? What's the difference? So type 1, they don't have insulin. Type 2, what's the problem with type 2? Not enough insulin. The way I look at it is you have all these receptors and they're clogged. They are just on strike, they're not working. So you're going to give them stuff that will stimulate the receptors, okay? They have receptors, but they're just on strike, they're not working. So that's why it's a totally different type of medicine. And because you don't have insulin, because they have a little bit of insulin in the body, they don't make ketone bodies. In order to make ketone bodies, you have no insulin. You have a little bit of insulin, you don't do this pathway at all. Okay, so that's why when people have type 2 diabetes, they don't go into acidosis. Does that make sense? All they do is just build sugar up, and build sugar up, and build sugar up, because it can't go anywhere. It doesn't go into their cells. It stays in their bloodstream, which is why they have such phenomenally high blood sugars, 1,000. DKA will have 200, 300. Type 2 diabetes will have 1,000, 600, 800. And so if you have that much sugar in your bloodstream, what do you think they're at risk for having?
A stroke.
A stroke, right? Because there's only so much osmotic pressure you can have, and then the sugar molecules start crashing into each other, and it gets sludgier and sludgier, and you can have a stroke. You just can't get anything transported around. Does that make sense? So they have some insulin. These folks, the type 1, have no insulin. That's the big difference with the pathophysiology. Okay. So they make what's called, oh my gosh, hyperglycemic, hypermolar, non-ketotic syndrome. Well, it explains everything to you in that hyperglycemic, what do you see? High blood sugars, right? They are hyperosmolar because you have so much sugar in there. Non-ketotic because they have a little bit of insulin so they don't go down this pathway. Syndrome. So that describes everything you need to know about what that person has. And again, it happens later. It's not the teenager or the 20-year-old. Again, our body tries to compensate with the hyperglycemia by making Kool-Aid, by peeing out sugar as much as it can. Again, the infections and medications can cause it. A lot of people will die from this. And why do they die? Because of the strokes, because of the clotting. indigestion. They die from it. Normal blood sugar is 100. Now you have 1,000. That's tenfold. What happens to everything else is a total arrangement, total chaos in there. How long does this take to occur? More than a day, 2 days, 3 days, like a week. It's a long, slow, insidious problem. And they get very dehydrated. So, what are you going to see? This looks like a lot of other problems that you see, doesn't it? It looks like you have polyuria, polydipsia, dehydration, you're going to have skin tinting, altered mental status because you have so much sugar, you don't work. They have coma, they have seizures. Has anyone ever seen someone who had this? It's like usually a 70, 80-year-old person who didn't know they had this problem. They don't go to the doctor because, oh, they've been to, you ask them when's the last time they've been to the doctor and say, yeah, 20 years ago. And it's a slow, gradual process. So when you saw it?
Saturday.
Oh, Saturday, excellent.
Yeah.
Nice.
They were going into more of the symptomology of it, but they were going down that path.
Did you recognize it?
What was it?
Did you recognize it?
The hospital would have also the day before when they discharged him if they did labs.
What was his sugar?
When I got there, high.
Okay, okay.
So at that point, over 600 on like the contour.
And the day before when they presented to the hospital, what did they present with them?
Kind of like intermittent altered mental status, a mild hypotension, dry mucosa, pallor. They were going down that route. They were, the gross lethargy was a big deal. They ended up having a fall at home, BLS at a finger stick, and it was in the 500s as well.
And they discharged them because?
I'm not a doctor.
I'm not a doctor. But they could discharge them because they thought that, sometimes people get tunnel vision and they say, well, we corrected the sugar, we gave them a medicine to bring down the sugar, but they forget about all the electrolytes, that the fluid changes are huge, and they don't do well. The process continues. So, it's important to be able to differentiate the two. So again, manage ABCs, same man, you want to give them fluids because they're going to be volume depleted. And will they have a ketotic breath? No. Well, whenever they don't have a ketotic breath. So we have too little sugar, 2 ways. Too much sugar, now we have no sugar, okay? How do we get no sugar in our mitochondria? What happens? How do we get there? There's so many routes to get there. I'm running a marathon and I don't eat because I don't want to take the time, because my time, I want to be my personal best. I've taken more insulin because I'm going on a road trip and I don't want to stop or I'm going to be on a plane. I've started to vomit because I've had food that disagreed with me and now I'm throwing up, but I took my insulin. I have problems, right? Someone who takes metformin, which is an oral medication that you can take to bring down someone's sugar. How long does metformin last? 24 hours. So I would see lovely problems where people are vomiting, they're on metformin, and they didn't address. They said, well, it's a short-term drug. It's like, no, it's not 24 hours. So they just went home and sipped soup. They came back crashing. It's like, no, you have to make sure that they can eat. It's huge, okay? Low blood sugar means that your brain doesn't work, your heart doesn't work, your muscles don't work. You don't function. And do people realize that they have low blood sugar? Most people, okay, if you are a new diabetic, are you going to recognize it more than someone who's been a diabetic for 20 years? I mean, 20 years, they have experience. They know what the diabetes is like. Do you think they'll recognize it better at 20 years? No, they recognize it worse, because basically diabetes affects your nervous system, and the nerves don't work as well. So if you're for me, first year of having diabetes, you'll be pretty good at it. But by 20 years, you have autonomic nerve changes, full range changes, and they tend not to recognize it as well. So it's important for them to perhaps live with someone that can recognize them. If someone says their blood sugar is low, believe them. And then when you give someone to something to raise their blood sugar and it goes up, what's the next thing you should do?
Give them-
Bye. See you later. Yeah, you check them again, because what went up is going to go down again, and you don't know how fast. So again, mental status is used. If you have too much sugar, you can be confused. If you have too little sugar, you can be confused. So, and they look cool, pale, diaphoretic. They can have seizures. It's like for someone who's hyperglycemic. But they typically have a normal respiratory pattern. If I give someone D50, 25 mLs of it, how long does it take them to wake up? The sugar was 10. How long does it take them to wake up? 4 minutes, 5 minutes, 7 minutes? How long?
Depends on how fast their sugar is raising, because why did it drop? If they took too much insulin, now you have to counterbalance the insulin that's still in their system and then raise it.
Right.
So
But most people, if you give them, because when you give them that amount of D50, it's going to raise it to about 160. So if you're giving them an amp of D50 or half an amp of D50 and nothing happens, chances are, you check the sugar again, chances are it's not a sugar problem. There's many other things that can cause altered mental status, narcotics, blood pressure, poisoning. But again, yeah, when you give it, usually it's about half a minute to a minute. If someone's blood pressure is good, the circulation is good. And has anyone done this yet and seen it in the field? Isn't it the most amazing, cool thing? Doesn't make you believe in science. It makes you believe in science. It's almost like giving a Dempsey. Watch the heart stop thing and go back to normal. It's like, wow, it's cool. But this is cool. It's like, my gosh, they need sugar. And then they wake up. It is incredible. So, how many people that you've seen who have hypoglycemia have had wristbands, identification saying that they have diabetes?
Usually it's like families and they're like, oh, my mom's diabetic.
Does the person typically have something? No. Well, it's amazing to me that so many people don't have a wristband identification. So usually when I was chatting with them in the ER, I would suggest all different markers that they could have that would make it easier for the DMs, easier for everyone, so that they would be identified. Because what if they weren't with the family members and they were in the grocery store and they closed? Well, no, it's time for Snickers. Right. So we usually could give prolonged fast alcoholism, alcohol will drop some blood sugar. Also, the most interesting cases they had was a little kid who accidentally didn't get it in a bottle of alcohol, they got it in a bottle of anti-cough medicine, which had alcohol in it. And I didn't even think that his blood sugar was low. It took me once, oh my gosh, it was in the 20s. Because the alcohol impedes the metabolism of insulin and glucose in the body. Most people who are alcoholics will have low blood sugar because of they drink their calories. That's part of it. And also, people who are alcoholics, what do you think about the Lyme status? You know, you have ADH, antidiuretic, hormone in alcohol. It kills it. So they're usually really dehydrated. So to manage it is basically first, if they can swallow something, that's great. Give them OJ, sugar, glucose paste. Give them 25 to 50 grams and 50% dextrose, which is again a quarter of what you have in that soda. Isn't that amazing? It's amazing to me that we make sodas that much sugar. Now glucagon, if you're not, you can't be sensitive to glucagon, because what makes glucagon? It's the beta cells, the alpha cells. Alpha, cool. And so glucagon will increase the glucose in the body. How long does it take to work? lots of wrong answers, one right answer. Range. 3 to 5 minutes. It all depends on how. But when you give someone glucagon, what's the most common thing you'll see? They will throw up because it works on the smooth muscle. They'll barf. So be ready for it. Be ready to protect the airway. So again, can't give glucose, dextrose, you give glucagon. And here's in a nice format for you. Okay. So again, diabetic ketoacidosis, they're going to have ketones, they're going to be acidotic. Hyperglycemia, hypermolar, non-ketotic, they will not be acidotic, but they'll have high blood sugars, but they will win the race. Diabetic ketoacidosis, blood sugars, not as high, 250, 300. HHNK, 600, 700, 800. Okay? You're going to end up treating them similar. They're going to be dehydrated. So you need to give them fluid. You need to transport them. You need to be aware of perhaps they're septic as well, and that's what caused them to go into this. Sepsis is a huge cause of HHNK. Okay. Questions? The last type of diabetes. One more time. So, has anyone known anyone who's been on like the semi-glucotized GLP-1 medications that are used to drop someone's blood sugar, weight, decrease in cardiovascular stuff? You know, you've heard about it all. You've seen lots of people on it. I'm sure you've see people on it. So does anyone know the side effects of it? The most common side effects of that stuff? Yes, it slows down your stomach. So you're slowing down the stomach, which makes people then 20% of the people in the first 2 weeks will have slow gastric emptying, which makes you not want to eat so much. It makes you vomit. 9% of people in the first 2 to 3 weeks will have vomiting on the medication. 8% will have diarrhea. 5% will have abdominal pain. So it's something to be aware of. Did you start a new medication? And when they say all the different formulas from Wegovy to fill in the blank, that these are things that you're looking for. Long term, when people are on them, you'll see young people having gallstones. This affects your lipid metabolism. So they'll have gallbladder attacks. They can have pancreatitis. Okay, those are the common things that you see and say, why is this young person having pancreatitis? Why is this person having gallstones? Okay, it's because the medication is set them. So it's a whole different class of medicine. So we have to start to think about what it is. There. Does that make sense? You'll be seeing, and they're very popular medications. You'll see a lot of people have. Okay. Questions on that so far? All right. So gestation. I'm going to switch to gestational diabetes. Why do you think there's gestational diabetes? What's that all about? How does the fetus get nutrition? The umbilical cord, right? And so it gets through diffusion in the placenta. So if someone has low blood sugar, the fetus is not going to do well. So the fetus is basically saying, I need sugar. And they're giving hormones to make the mother have higher blood sugars so that the fetus can get sugar. So when it's really out of balance, you'll see people who have very large babies, 10 pounds, 11 pounds, because they had so much sugar and diabetes. And it's very hard to control. Do you think the folks who've had gestational diabetes are at a risk of having diabetes the rest of their life? Yes. About 80% of people who had gestational diabetes will have become diabetic, type 2 diabetes. It's because think of it as a stress test for your sugar metabolism. So it's a very large percent. So you're going to see folks with diabetes. And so if someone tells you that they have gestational diabetes and I'm going to deliver the baby right now and I broke my lottery. What's your biggest concern? Besides, boy, I love doing deliveries, right? Everyone loves doing deliveries. But they can be shoulder to social, they can be really, really big babies. So that's an important part of the history to know when someone's pregnant. Do they have gestational diabetes? That's huge to know. Because the kid can be huge and you can have shoulder dystocia and chromosome. Okay, all the complications of diabetes you have seen, because basically what happens is when you have so much sugar in your nervous system or your blood system, it gums up the works. Back we got a thing, and so they doesn't look as well. And it starts, most complications, you have to have diabetes for at least 5 to 7 years. Someone says, I'm diabetic, I've been diabetic for 1 year, and then I'm blind now. It's like, well, how long did you have symptoms for? If someone's well controlled, you tend not to have any of these problems, but a lot of people have not been able to control them. Peripheral vascular disease, people used to have lots of toes, feet, being amputated. It's rare to see it now. I mean, have you seen many people who've had bits taken off because they're diabetics? And you're older, right?
Yeah, today I saw him with the big toe chopped off, and they were probably going to get less than half of their food.
Why do you, have you, when you saw someone, has anyone seen someone with a diabetic wound?
Mhm.
Y'all, right? What's the thing that's most outstanding about someone with diabetic? It's so outstanding you don't even notice it. You look down and you see this fetid, gross, disgusting, oozy thing. And they have no pain. Right? They're not complaining of pain at all because they have a neuropathy. They feel nothing. That's how it happened. They didn't know their shoes were too tight. They didn't know their socks were rubbing and causing an ulcer. They had no clue. If they had a clue, they wouldn't get like that. They had no clue. They didn't feel it. So they say, oh, I don't feel it, so it can't be that bad. But when you look at it, it's like, oh my gosh, it's a horrific wound. And they're very slow to heal. They get infected, the bones get infected. But I think it's really outstanding when you see a diabetic wound or someone has a wound and they say, it doesn't hurt me much. It's not because they have a high pain tolerance. They have no pain receptors. They kill them. Okay? Just to keep that in mind. That it's a sign of how bad the diabetes or how brittle it is. So, you all know how to do blood glucose? Yes? Good. That. And so, questions on diabetes? Yeah.
So for those persons who have the leg wounds, and they're not feeling anything because you said they have neuropathy, they don't even feel like if there's maggots in it, crawling in it.
Right.
They don't feel the maggots.
Right. Right. It's impressive. Maggots work really well. I mean, they clean out the dead tissue. But they don't feel it. No. And it's not because they're bad people. It's not because they don't have a brain that works. Their nervous system doesn't transmit it because it's been altered. It's been turned off. You can't say, how come you didn't feel that? It's like, no, it's like, I get it. You're diabetic. Your nerves don't work. But for most people who are well controlled, it doesn't happen. Okay. So, awake, didn't need a break at all, you're good? So we talked about hypothyroidism, we talked about thyrotoxicosis, my other housemate, who had the eyes, the psychosis, the rapid heart rate, the sweatiness, and just crazy. And she had to get it. And when she got treated, boy, did her personality change.